Everyone, this is the Psychedelic Support Monthly Speaker Series. I'm Dr. Allison Feduccia, your host. And I just wanted to take a moment to thank you all for showing up and your willingness to come here and share and learn together. Psychedelic Support is experiencing a phase of tremendous growth. A lot of this is from Michael Pollan's recent release of a Netflix documentary on psychedelics. And at this point of inflection, we are seeing a lot more individuals getting curious about psychedelics or seeking them out for agents of healing and personal growth. And with this opportunity, I did just want to let you know that we have a network directory of over 1,200 licensed health providers. It's free to join, and I invite you to check it out. There's a link here in the chat. And, really it's about doing this work together so that we can provide the best possible care and do this in an ethical and careful way. I really do truly believe that psychedelics do have a lot of potential for healing and transformation, but they're not going to be the right fit for every person. And that's why I invited Dr. Dave Rabin to join us today to really talk about how to approach ketamine, MDMA, and psilocybin in particular, as we see these are going to be becoming FDA-approved, possibly in the coming years. And I'll also invite Dave to share some alternatives for those that maybe can't access psychedelics right now, or that maybe it's just not the right fit for them in particular. So we'll host this session for an hour. We'll probably have some time for Q&A. During the session, you're welcome to chat with each other, drop in where you're calling in from, your profession. If you want to try to connect with others for any particular reason, feel free to share that. I'm going to introduce Dr. Rabin now. Dave is a friend and also a board certified psychiatrist, neuroscientist, entrepreneur, and inventor, who has studied resilience and the impact of chronic stress on our lives for over 15 years. Dr. Rabin and his team work together with clients at the Apollo Clinic, where they empower their clients to take control of their mental and physical health by tapping in to our abilities to adapt and heal ourselves. In addition to focusing on integration therapy, plant and natural medicines, couples therapy, and medicine-assisted psychotherapy, Dr. Rabin specializes in treatment-resistant mental illnesses. He's also the co-founder of Apollo Neuroscience, which is a wearable device for stress and mood regulation. I have one, and it's a really, really cool thing. I definitely encourage you to check it out, and maybe he can tell us a little bit about that too during this talk. He's the executive director of the Board of Medicine, which is a nonprofit organization, physicians and scientists establishing evidence-based clinical guidelines for the production and safe use of currently unregulated alternative medicines, including plant medicines. So thank you, Dave. Thanks for being here, and I'm going to turn it over to you.
Well, thanks so much for having me. I really appreciate it. It's always a pleasure to be able to do these kinds of events together. So I'm glad we can make it happen. And it's nice to see you all. I see some familiar faces. So welcome, everyone. Hey, Jim. So how do you want to start, Allie? Do you want me to just jump in and talk a little bit about talk about myself and my journey, or should we, because I think we were going to bring up some slides at some point, right?
Yes. Do you want me to, yeah, you can talk about yourself. Do you want me to run the slides for you or drop them in the chat for you here?
Oh, yes. I can probably do that since you made me a co-host. I'll just bring them up. I think you sent them over email, right?
Yeah.
I'll bring them up here.
Okay, cool.
But I think, yeah, I mean, so thank you for the nice intro. I really appreciate it. I am a MAPS trained MDMA assisted psychotherapist, as well as a ketamine assisted therapist and a cannabis therapist, and a general adult psychiatrist and psychotherapist, trained in over, I don't know, probably like 10 or 12 different forms of psychotherapy. As a psychiatrist, I'm a bit unusual because I predominantly practice psychotherapy, And I do, medicine-assisted therapy in probably 50% of my patients with ketamine. But in general, I find that using psychotherapeutic techniques very thoughtfully, and when needed, you bringing in medicine to assist or catalyze the psychotherapy or amplify the psychotherapy techniques, like ketamine, used thoughtfully, even over telemedicine, can be an extremely powerful tool to prevent people from having to end up taking prescription pharmaceuticals for their entire lives, which is something that we try to avoid at all costs, because it's very stigmatizing and disempowering, and tends to result in more side effects and more harm to the client. However, as a general adult psychiatrist, I will say that there is a time and place for all medicine, and these medicines are just tools that are really useful to help us navigate very complex illnesses with patients. And so I'm by no means closed-minded to any of the tools that we have available to us, but I am, and the ethos of the Board of Medicine really emphasizes this, which is, I am very strongly in support of using medicines thoughtfully and respectfully, regardless of what they are, in the right context and frame, which is something that as a society and the medical community, I think we really have not done the best job of over the last 50 years, particularly with respect to medications like opiates and benzodiazepines. But I won't digress too far there. I think what really has excited me about psychedelic medicine, and what really spurred the development of and psychedelic assisted psychotherapy, and what spurred the development of the Board of Medicine and the bringing together of these Western experts who are mostly not psychedelically inclined, but who are open to the evidence that psychedelic medicines can provide dramatic healing opportunities for people who are struggling with treatment-resistant mental illnesses, is that constantly asking the questions of, how do we make people who are struggling lives easier, and how do we help them suffer less? And, looking at the statistics with people with PTSD, for instance, I think we see that patients with PTSD diagnoses in the US have a less than 50% remission response rate when treated with the gold standard of medications being Paxil and Zoloft, which are the only two FDA-approved medications, I believe, for the last 20 years, despite the fact that the NIMH, the National Institutes of Mental Health, was founded to treat PTSD in 1949, which at that point was called shell shock, which actually is PTSD and traumatic brain injury. To this day, we still only have two FDA-approved medications, Paxil and Zoloft, in the last 20 years that are actually FDA approved and indicated for PTSD treatment, which is, and with less than 50% remission rates, probably closer to 30% long-term remission rates, which means that 50 to 70% of people who actually receive a diagnosis of PTSD are still not getting better long-term. So this is a really important area of focus for all of us. And it's really encouraging to see all of you here. And this has led us to really seek out and ask the questions of how do we do a better job understanding trauma, understanding these illnesses and what we can do about them, and how we can support patients with non-drug alternatives like Apollo, which is the first of its kind as a wearable touch therapeutic, which we can talk about later. And also psychedelic medicines, all of which are interesting because they can be very, very powerful tools to activate and amplify the most fundamental foundation of what all psychotherapy is based on and healing is based on, which is trust and safety. And so if we are using the medicine in that way, and we're using our tools, whether they're, any kind of tools, breath work, meditation, mindfulness, yoga, exercise, Apollo, soothing touch, soothing music, what have you, psychedelics, et cetera, if we're using even prescription medicines, if we're using those tools thoughtfully with the goal and the frame of holding safe space for people, then we can facilitate radical transformation in our clients. But that really is at the foundation of everything that we do, and that therapeutic alliance is critical. And that's also why we're so supportive of Allie's work and psychedelic.support, because they really focus on making sure that people can be educated about these medicines and tools and how to use them safely and preserve the relationship with our clients. So that being said, should we jump into this presentation?
Yeah, let's do it. Do you have the slides?
I do. I'm putting them up right now. Can you
All
see
right,
them?
perfect. Yeah, very good.
Okay, awesome. So I think we're going to talk about today predominantly are psychedelics right for my patient, how to use them in practice. Um, Basically, starting with ketamine, because ketamine is interesting. It's the only legal psychedelic. And Allie, feel free to jump in anytime, but of course. So ketamine is the only legal psychedelic medicine to date. It's interesting because it became legal through a non-psychedelic pathway because it was used for pain and anesthesia and evacuating soldiers from the battlefield. It still is used for that purpose in the military. And it's a very, very powerful medicine. It's interesting in that it has very potent anesthetic effects, pain relieving effects at high doses that can be so powerful that they actually will anesthetize somebody to prepare them for surgical procedures. But at lower doses has these very interesting kind of euphoric, psychedelic, as in dream-like states of induction where you can effectively, in a very controlled way, take somebody into a ketamine-induced dream state that's like a lucid dream that can be guided in part by the therapist and by the client to help people understand their subconscious more effectively. And so it really is, and I emphasize dreams because dreams are the most fundamental, basic psychedelic altered state experience that all of us as human beings have experienced in our lives. So when we think about what psychedelic states really are, I'm sure you all know this, but psychedelic means to show the mind. So to show the mind or to reveal the mind is really to imagine our awareness is like the tip of an iceberg sticking out of the water. And that's the part that we are aware of. That's our conscious, what we're conscious of. Then there's everything beneath the iceberg, which is like 100, 1,000, 10,000, a million times bigger than what you see above the surface. And that's our subconscious or beneath awareness, beneath the surface. And so dreams are the way that we all, from as long as we can remember, have had access to our subconscious, because the filter between our ego, what we're consciously aware of during our waking life, and what we are aware of when our ego is not incredibly fortified and strong, we start to become aware of what's beneath the surface when we dream, because our ego is subdued. And that's normal because we need that ego survival part of our brains to be subdued so that we can rest and recover. So these are fundamental healing states that are required for recovery. Ketamine is fascinating because it's a synthetic substance that actually can reliably induce access to these dreamlike states. It's unlike other psychedelics, it's a bit atypical of mechanism. It's an NMDA receptor antagonist. It has a lot of other effects on the brain as well. There was a really interesting study that came out of Stanford a while back that I think, posed that ketamine's effects may be acting in part on the endogenous opioid receptors in our bodies, which is also interesting. That may be a dose-dependent reaction, but I think the effects of ketamine were blocked by naltrexone, if I remember correctly. Allie, you can correct me if I'm messing that study up, but there's a multifactorial mechanism of ketamine, which is important. Did I get that right? Okay, cool. So we talked a little bit about the duration of effect. How you introduce ketamine and the amount of ketamine introduced is dramatically impacting how long it lasts. So oral ketamine, because it has to be absorbed through your mucosal lining, ketamine is not typically, oral ketamine is referring to swallowed. So swallowed ketamine is not the best way to ingest ketamine because ketamine gets broken down very rapidly in the gut. And so when you take ketamine orally, you only absorb about 10%, 10 to 15% of what you take. So, you're talking, if you take 100 milligrams, which would be a very strong dose given as an injection, then orally you would need maybe 10 times that to get the same kind of experience, but the effect would last much longer because it takes a long time for the medicine to be absorbed and then brought into the bloodstream and then metabolized and excreted. So oral ketamine is not our favorite way to ingest ketamine. We typically prefer, in my practice and most of the practices of the folks that I work with, sublingual or transbuccal ketamine, which is typically not, it can last as long as 4 hours, but it generally, depending on how high the dose is, generally we see that lasting maybe on average 2 hours for people. And it's very, very safe. It requires you to swish the ketamine lozenges or troches in your mouth and hold your saliva for 13 or 12 to 15 minutes, because the ketamine absorbs better through the mucosal lining of the mouth, which is not the tastiest, but it does imbue a respect for the medicine that patients will generally be less likely to abuse it, because it requires a very significant investment to achieve the goal state, and that patients absorb dose-wise about 25 to 35% of the transbuccal medicine. So you're talking, if they take 100 milligrams of ketamine, you're absorbing, if you swish between 12 and 15 minutes, you would expect them to absorb 25 to 35 milligrams. So when we start people orally, we typically start them on, if they're new to ketamine, 200 milligrams, which would give them about a 70 for switch for 15 minutes, which gives them about a 70 milligram bioactive experience. And if they are very, very large folks, or folks who might have given us some indications they have a slower metabolism, or they're taking medications that would impair the activity of ketamine, like sedatives or hypnotics, then we would start them at 300 milligrams. But that's our go-to, because it's the easiest to administer, and often pharmacies can ship the oral transbuccal to an individual's home. And then there's intramuscular and IV, which I think is the choice if you're in person with a client and you have the opportunity to give an injection, or you're comfortable giving an injection. This is the fastest route, because oral sublingual ketamine takes about, I want to say, 15 to 20 minutes to onset in effect. Intramuscular IV is 3 to 5 minutes or quicker. And so the experience at peak state, where the medicine is peak active, is much longer. So it's you can have an hour or more of peak state, whereas with the oral and sublingual, your peak state is more like a steep curve. So you're only at peak for maybe 20 to 30 minutes, rather than being at peak for the whole hour or so. So there are advantages to intramuscular in particular. We don't like IV, because some people really like to move on ketamine. You don't know who that's going to be. And people with an IV in their arm you don't want them to move, or if they move, it could be bad and they could puncture something you don't want them to. And so we prefer not to use IV. IM is really nice, because you just pop in their shoulder and then you're done, and then they can move or do whatever they want. And it's easy to give them boosts too. Intranasal is another way that we commonly use ketamine. It is not it can be used, and used for like low dose ketamine experiences or maintenance therapy. We tend to not use it, even though it's extremely convenient, because it's extremely convenient, almost too convenient. And so what we've seen in the literature is that patients, or people in general, when they abuse ketamine, they abuse the intranasal form most often. And so we know that ketamine is an anesthetic, or has anesthetic properties. And so what anesthetics do, and they have anesthetic properties, even if they also have psychedelic properties, is they numb us to our feelings. And so if you have the option to carry your intranasal ketamine in your purse or your bag or whatever, and then, say, oh, I'm having a bad day, I might as well just squirt some ketamine in my nose, then not feel my feelings right now, then you're really defeating the purpose of what the medicinal experience is all about, which is to engage with your feelings and to do it intentionally. And so we want to avoid encouraging numbing and escapism behavior, which the intranasal just does by nature of it being so convenient. And so we generally avoid using it. I think I also come at this from the perspective of I'm an addiction psychiatrist and a trauma psychiatrist. So I deal with a lot of people who have both of these diagnoses. And so I think that, we see a lot more problems in patients who have the intranasal form of ketamine than other forms of ketamine, because it doesn't require the same kind of intentionality to use it. So I think that, yeah, please.
Do you treat patients with addiction disorders with ketamine? And how do you approach that?
That's a great question. So, especially because addiction disorders are so common. So it depends on the drug they're addicted to. If it's cannabis or nicotine, for instance, the answer is absolutely yes. Those are not contraindicated. If they're addicted to a sedative or a hypnotic, like a benzo or an opioid or alcohol, or they're addicted to a stimulant like cocaine, crack, and amphetamines or things of that nature, things that either numb or distract you, or if they're addicted to psychedelics, then we tend not to use ketamine until we have successfully established a period of abstinence and sobriety. So drugs are not always the answer to problems caused by drugs. In some cases, they can be when used very carefully. So the example of that would be that, I've had patients who come to me, they are drinking 4 to 6 drinks a night for months or years. They are clearly admitting and recognizing that they want to stop numbing themselves to their problems, but they've entrained themselves to be in this state and this pattern. And so what I'll do with them is I'll work with them on a psychotherapeutic basis, primarily give them some healthy supplements like CBD and CBDA are great supplements. If you have any curiosity about what products are the best for patients, we've vetted a number of them at the Board of Medicine, which will be announcing over the next month. But if you email me, I can send you the recommendations for those. And that has been an incredible resource. Believe it or not, microdose lithium is really, really helpful for tapering people off of sedative and hypnotic and stimulant abuse. With microdose, I mean 5 milligrams daily of lithium. So very, very low. It's like 1/100th of what you would take if you had bipolar disorder. But most of us, it turns out, may have lithium deficit in our diet because lithium comes from eating naturally dirty food, and we don't eat food that's dirty anymore from the soil. So we might be, it's thought that in the human performance world that we actually might be lithium deficient, which causes a lot of mood lability in many of us on a daily basis. So I find that lithium is extremely helpful in this regard. And then, of course, teaching people also breath work, meditation, and adopting new routines to manage stress are critical. Once they've then established about a month of sobriety, then we will give them a single dose of ketamine, assuming that they say they're ready to do it, and we have established an alliance, and we'll give them one single dose of ketamine, which gives them a peak experience based on a lot of preparatory work focused on gratitude practice and self-compassion and self-forgiveness and self-love, and really helping them facilitate doing some of the deep therapeutic work. And then from there, we'll do a lot of integration, and then gradually, when appropriate, do subsequent medicine sessions with ketamine. But these patients are naturally vulnerable given where they're coming from and their starting point. And so we have to be extra, extra careful to not accidentally enable them to abuse the ketamine, because the ketamine will be an extremely powerful tool to heal them. But if they develop a similar relationship to it, which is very possible, especially if they abuse sedatives and hypnotics or stimulants, if they adopt a similar relationship to it or a similar association to it as they had with those hypnotics or sedatives or stimulants, then the healing potential and power of the medicine ends up getting sidelined for the anesthetic seeking effect or the numbing effect. Does that make sense? Cool. So yeah, and cannabis, nicotine, I found to that point, nicotine addiction, I think ketamine can be very helpful for. I still do the same practices of trying to retrain behavior and give people these stabilizing tools. Apollo's been really helpful for that too. But ketamine, when used properly and intentionally, can be very helpful for cigarette cessation, nicotine cessation. Cannabis is a tricky one, but in general, cannabis and ketamine get along well together. Cannabis can extend or increase the psychedelic effects of ketamine. And so we don't necessarily, when we're talking about like the lesser of two evils, if we have somebody who is using cannabis the most common case is somebody's using cannabis to self-medicate their symptoms of PTSD because they don't have anything else or everything else has failed, and then they want to try ketamine, but they're afraid to stop using cannabis. What we'll do is we'll actually taper them off of high THC containing cannabis compounds to ideally full spectrum cannabis that focuses more on a 2-to-1 ratio of CBD to THC at the least. So ideally, products that have more CBD ratio to THC, 2-to-1 or greater CBD to THC, have a greater mood stabilizing effect, and for people with PTSD and chronic pain, a greater pain relieving effect, and emotional and physical pain. And so without so much psychedelic effects or the sort of stimulating effects of the THC that can happen when you use THC chronically, in particular high doses, which surprisingly for a lot of people can actually result in anxiety. And so helping people understand that they can rebalance their cannabinoid system by just shifting the ratio of cannabinoids to more CBD than THC, more CBDA than THC. CBDA is the raw acidic form of CBD that's even more anti-inflammatory and more mood stabilizing than CBD itself, which is the heated form. The CBDA comes from raw cannabis leaves or hemp leaves, very, very useful, very, very mood stabilizing. So these are all sort of tips that you can use for managing these folks. And so these, you've been looking at these probably while I'm talking, these are some of the subjective effects that we've described already for ketamine, which are dose dependent. I think the most important thing to note here is that, number one, you want to hit a threshold of ketamine around 70 milligrams bioactive. So that would be 200 milligrams of sublingual ketamine swished for 15 minutes to get you that 70 milligram threshold for a person of average height and weight with no psychedelic experience, or 70 milligrams of injected ketamine, roughly, for the same person, to get it to hit a threshold state where people really start to experience the psychedelic altered state of consciousness, ego dissolution, ego subduing, gentle ego subduing, entering into a dream state. But they're entering into a dream state, and why the dose is so important to start there, especially with somebody who's new to ketamine, and not say, oh, more is better, let's just blast you off, which so many people do, and it's not good. Because the problem is that people who get blasted off, especially if they don't have the preparation for it, could be very, very surprised by what they find, which is basically ego death or nothingness, and not know how to integrate it. But the other problem is that ketamine is an anesthetic. So it impairs memory. So there's a sweet spot for people that we generally find between where they just start, for the average weighted person, 70 milligrams, they just start to feel that ego subduing, gentle entry into a dream state, sort of altered experience, some euphoria, some relaxation, some anxiety reduction, sort of pausing of the ego, pausing of the narrative in our minds that's playing over and over again, and a sense of just being, right? And so when you hit that sweet spot, that is generally where we want to stay. And we want to titrate or tailor the dose to keep hitting that spot for people without going unnecessarily higher, because when we go higher, what ends up happening is people don't remember what they learned from the medicine experience. They forget because of the anesthetic effects. So it's a very delicate balance, and that's the most important thing I think to note about the dosing and why it's different than using ketamine for pain management, or why it's different from using ketamine for anesthesia in the OR, because they're using doses much higher than what we're using. And if I could give one piece of advice or lecture to everybody who runs an IV ketamine clinic, this would be it, because they'll get way better outcomes if they don't dose people at such high doses. And of course, the adverse reactions similar to other psychedelics, but with ketamine in particular, nausea and vomiting is a big one, dizziness, anxiety, decrease. I think the most common, that one that happens for everyone, is that ketamine makes it hard to move because it's dissociative from your body. So when you leave your body into the dream state, then you come back into your body and your body seems a little bit unfamiliar, and you kind of like walk like a toddler and feel like a robot. And so people need to move very, very slowly. What we found is that people who have nausea, dizziness, and vomiting as a result of ketamine use have it usually because they don't realize what dissociation feels like. And they don't realize that when they come back into their bodies that they're not used to being in their bodies because they've been out of their bodies for 1 to 3 hours. And so what happens is people go back into their bodies, they're like, oh, I'm back. And then they start sitting up and moving around and doing things the way they normally do, but their bodies and their minds are still slightly dissociated. And so it creates a vestibular disturbance, which creates dizziness, which makes people want to throw up and makes people nauseous. And so this can be avoided by making sure that your clients do not move quickly after the experience is over. There should be, again, this is an issue with in particular in IV and IM rapid flow clinics, because people only get to sit in the chair for an hour and a half, and then they get kicked out and they have to go home and walk around. And so we actually do 3-hour sessions in our clinic with a little bit of prep before and a little bit of integration afterwards, where the patient is basically lying there for the whole time for at least 2 hours with a blindfold or eye mask on, in a quiet, dark space with a little bit of light, gentle music playing. The music is absolutely critical. I can't emphasize that more. The music is absolutely critical. We can put together, we have a bunch of interesting playlists that we can share with you if you're interested, that are very reliable, and can really gently guide somebody through an experience in a non-aggressive way. So I think the main thing is helping educate the client to understand that they should not be moving quickly afterwards, and that their bodies will feel different. And then most of these side effects can be avoided. Sedation is going to happen to everyone basically. Confusion is pretty rare. Increased vitals are pretty rare. It does happen sometimes, but it's pretty rare. I think the other one is anxiety, right? So anxiety starts actually before the ketamine is actually administered, because it's typically begins with apprehension to the new experience, or apprehension to the experience you're about to engage in. And so therefore, you want to make sure that people are prepared adequately, which means, to the best of your ability, explaining to the client what they're going to experience and helping them understand that the whole point of engaging with ketamine is to let go of control over the experience, let go of control over anything about what's about to happen, because you are diving into this right now to become aware of your subconscious, to enter into your own personal dream. And so for the medicine to really do its work, the medicine works by showing people what they were meant to see, which is based on intention, and it's based on the individual letting go. So part of what we've been doing is teaching breath work, doing stretching in advance, doing a lot of mental and psychological preparation. We teach the 4 pillars from Shipibo tribal medicine that I mentioned earlier, which are self-gratitude, self-forgiveness, self-compassion, self-love. Those have been very, very helpful for people. We use the Ho'oponopono prayer from Hawaii, which is, I'm sorry, please forgive me, thank you, I love you. We use, these are like incantations of presentness and intention that are really helpful that people can repeat during the sessions. And we use the 4 agreements, which is another great guide, which is don't make, in advance of the session, don't make expectations, don't take anything personally, always do your best, and always be true to your word. And these 3 sets of principles kind of serve as really powerful guides that are sort of guides of understanding to people going in. Gratitude is always the best intention. If somebody's in doubt about their intention or what they should focus on, gratitude is always the first place to start. You will never go wrong starting with gratitude, because gratitude for just being here today, for taking the time to have this experience for yourself, to prioritize your healing journey right now, here and now. These are the things that anyone can find gratitude for and thank themselves for, and that tees up the experience for everything else, for letting go and sort of leaning in and letting everything else come that will come. The other tool that we use that's currently in clinical trials is Apollo, which is, again, the wearable touch therapeutic. It looks like this guy here. This is a clip that's coming out in a month. But it straps onto your body. You can wear it on your wrist or ankle or arm. It has 2 buttons on it. You can set it to rebuild and recover mode, which is the mode that is most autonomically balancing, most gentle and even for people who have anxiety going into psychedelic experiences. We've had a lot of great findings about people experiencing having much better psychedelic experiences when using it before, during, and after, because it basically gives you the benefits of deep breathing without actually having mastered deep breathing yourself by just turning it on. And so people who have apprehension, anxiety, use it before going into ketamine experiences. We have several ketamine clinics testing it, using it now with their patients. We have a big IRB-approved trial, multi-site, that's going to be launched shortly for ketamine. And then MAPS is using it and recommending it to all folks who have participated in the MDMA-assisted therapy trials with MAPS for PTSD as an integration tool afterwards. So these are all different things that you can use that can help facilitate that process. And let's see. So ketamine is FDA approved as Spravato, which is one form of ketamine. It's the enantiomer esketamine for treatment-resistant depression in conjunction with regular antidepressant and major depressive disorder with suicidal thoughts and behaviors. It's in phase 3 trials for major depression. It is in other trials, other phase 2 trials for other depressive syndromes and for PTSD, and for other disorders listed here. I think the other thing that's important to note is that regardless of how we look at mental illness, the thing that's in common with basically all of these disorders is trauma. There's almost always a traumatic event at the root of what's going on here. And so if we think about the way ketamine works to address trauma through becoming aware of our subconscious material and then understanding it with gratitude and forgiveness and compassion, and then bringing that forth into our lives through integration and practices, this is the same way that MDMA and psilocybin work. The actual fundamental principles, and the same way that the tribal shamans of thousands of years old have used ayahuasca and peyote and all of these other medicines, are all based on the same principle of getting to the root trauma that is blocking us from just being ourselves and blocking us from really just being. And so all of these disorders, regardless of what name they have from the DSM, are all trauma-based disorders. And ketamine effectively works very well for them. So ketamine, despite being FDA approved for depression with Spravato, which is actually the most expensive and form of ketamine to get, it's the most restricted and it's nasal spray only. We actually can use ketamine, cheap ketamine, which is racemic ketamine, which works equally well, off-label, it's off patent, and it's extremely cheap and effective for the patients. That's typically what we recommend most people do. And you can get it from any compounding pharmacy nationwide. So that is, and so that is one of the major things that the oral forms anyway, and sublingual you can get from the compounding pharmacies. The injectable racemic ketamine, you probably need to order from a special sourcing company. But the point is that these are transdiagnostic tools, so they can be used across diagnoses off-label, which is important to note. And now getting to some more stuff. So okay, move to MDMA, Allie?
A little bit too, because we want to do the case examples.
Oh yeah, yeah. I'll try to be
most people are probably pretty. I really loved everything you're saying about ketamine. Such a wealth of information there. But yeah, if you could go through the MDMA and psilocybin and just prop us up for the case examples. Thanks.
Yeah, I'm gonna go through these. Try to go through these a lot quicker. So because we already covered the whole basic principles of how all these work. So MDMA is a atypical psychedelic as well. It's a more stimulant-based psychedelic. It's of the methamphetamine family. So it's not as psychoactive in the typical sense of facilitating access to like dream states or paranormal altered state experiences. It's very clear, very crisp, very safe, safety enhancing, longer mechanism of action, or longer bioactivity, taken orally, talking 3 to 6 hours for most people, 6 to 8 if you add a supplement dose. Acts primarily on the 5-HT2A serotonin receptor, which then goes downstream to dopamine receptors and other receptors in the body that are involved in reward center signaling. And the typical dose is about 75 to 125, depending on weight. Subjective effects, I think most of you know, enhancement of empathy, enhancement of safety, radical self-acceptance, radically reduced fear, radical trust, especially with self and the provider, radical non-judgment, right? I say radical because it's a radical shift from normal mind. Very, very interesting. We also often call it affectionately child's eyes. It's like almost looking at yourself through the eyes of yourself as a child before you knew how crazy and wild the world could be. Adverse reactions, most common are anxiety, increased heart rate because it's an amphetamine. So anything that amphetamines do, MDMA has similar side effects. So nothing really new or exciting there. MDMA is not approved yet. It's currently in phase 3 trials for PTSD. It is in phase 2 trials for alcohol use disorder in England, and led by Ben Sessa, and social anxiety autistic adults, led by some wonderful folks in California. I think Charles Rabin and someone else whose name I'm forgetting is leading that study. And it is very, very nicely combined with psychotherapy, cognitive behavioral stuff, dyadic therapy, ideally where you have 2 therapists. We also do 2 therapists for ketamine, and for any psychedelic experience, we do 2 therapists because it tends to work better and help navigate transference issues more effectively, and also allows people to take a bathroom break. Psilocybin is one of the more classic hallucinogens in that I don't really like the name hallucinogen because it's really just showing us what is, not what is not. So again, showing us our subconscious is very real. It's also a 5-HT2A partial agonist, so it changes activity at 5-HT2A serotonin receptors and also augments activity at these receptors, which LSD also does, but in a slightly different way. And psilocybin is about 4 to 6 hours, depending on the mushroom. I think it's very, very important for people to know that people who consume mushrooms, that there are, or patients who are consuming mushrooms, there are hundreds of different kinds of psychoactive mushrooms. So make sure that you understand the dosages of what people are taking, what kind they're taking. They're all different strengths and they're all different effects, as Jim knows very well. And so you can, you definitely want to know, if you're using a whole mushroom, what that is and how strong it is and what kind of effect it has. And this is really referring to actual psilocybin extract. So the oral dose for psilocybin extract, whether that's is about 10 to 30 milligrams extract, or I should say synthetic psilocybin. And these are the things people have seen commonly, which we talk about a lot: vivid imagery, visual hallucinations or distortions, which I would prefer to think about as seeing as it's like a shift of the filter, right? So you're shifting by augmenting activity or changing activity at the 5-HT2A receptor. The way that psilocybin does, it creates a response whereby the filter, what we call it the colostrum, or the thalamic filter that filters incoming information from the environment, is disrupted a little bit. And so our ego filter is allowing things through that would not normally get through, which allows parts of our brains to talk to each other and coordinate information and organize information in ways that we would not normally be doing, which then results in us detecting and seeing patterns in things that we would not normally notice or be aware of. So it's not, hallucination kind of implies, and why I don't like the word, is that it implies that what people are experiencing is not real, or it's made up by the mind or manufactured. It's actually, I think, quite the opposite. I think what people are experiencing is very, very real, but it is a window into their subconscious. And so how they interpret what it is they're experiencing is really where the magic happens with the guide, and the preparation and the integration work. And so there's also altered auditory perception, synesthesia, feeling and seeing, feeling colors and seeing music and all these kinds of things, mood enhancement, antidepressant effects, ego dissolution, similar to ketamine. It's transcendence of space and time. I don't need to read all these things to you. I think most of you are familiar with this stuff. And similar to MDMA, we see anxiety as being a component, and ketamine. This is common with all psychedelics, but I think that one of the things that happens with psilocybin and psychedelic medicine of the variety that psilocybin is that we see paranoia come up sometimes more often with these medicines, because it makes us more open to what's beneath our subconscious. And so people who have not been adequately prepared, or who have had tremendous amounts of trauma and hardship despite adequate preparation, especially when they have a lot of distrust in their history, especially distrust in the healthcare providers that they've seen in the past, can experience significant paranoia during these experiences, no matter how safe their environment is. And so these are things that we need to account for going in, and make sure that we as a therapist are prepared to manage that when it comes up, if and when, which it very well can when we least expect it. And then the same blood pressure can be increased or decreased with psilocybin. People can have headaches, yawning, sometimes nausea and GI stomach upset are pretty common depending on how the mushrooms are ingested. Typically, it's more common with whole mushroom ingestion. And psilocybin is currently in phase 2 trials, mostly for depression, nicotine dependence, cigarette cessation, alcohol use disorder, PTSD, GAD, OCD, and also benefits dramatically from psychedelic or from assisted psychotherapy. And really, all of these medicines benefit from what we call a non-directive approach. This is an approach that I think MAPS really focus on pioneering. Ali was a big part of that, from my understanding, whereby we don't tell the patient what to do. We gently guide them in the experience when the medicine is active, and we serve as support and non-directive guides, whereby we really make them at the center of the experience and let them guide themselves with our safety and encouragement. So getting to the case studies. How do you want to do this, Ali? Should we just read through?
And yeah, your thoughts on any of this?
Sounds good. These are not real pictures of these people, right? These are just pictures you found.
No, yeah, these are all just made up possible case examples of what type of clients might be coming to practitioners.
Awesome.
Yeah.
I feel like I know some of the people in these pictures, which is really funny.
I think they came from Canva.
Nice. Okay, then I definitely don't know them. Okay, so Laura just started a new career, struggling with depression after a decade of trying talk therapy, SSRIs, and SNRIs, serotonin, norepinephrine reuptake inhibitors. She wonders if she'll ever find something that works. This is probably my most common patient. Laura is somebody who has been, functionally disempowered by the medical system, and feeling like she's, tried everything that's been offered to her that, from our standpoint is the gold standard of care, but not addressing her problem long term. I think, and really, had multiple trials of stuff that just hasn't worked, which of course, from the patient's perspective, is very disempowering and disheartening. And so with folks like Laura, when they come in, often what we do is, start with some talk therapy, do a few sessions of talk therapy and get to know the person, make sure they feel safe with us, and we've established a trusting relationship. One thing that I do that I feel like not enough therapists do, that I would highly recommend, is do a dietary and supplement consultation. If you feel comfortable doing that yourself, by all means, do it. If you do not feel comfortable with your expertise providing a supplement consultation yourself, find somebody else who can do it. There are lots of people who will do it. It is worth doing. There are a lot of people who will over supplement themselves, especially these days, because they think that more is better. It's actually not. One example that's really important to note is vitamin D. Vitamin D toxicity has the same symptoms as vitamin D with too little vitamin D. So if you have too little or too much, then you can experience the same mood issues, for instance, as in both situations. And so we want to make sure that, ideally, as the treating provider, we understand all the things that somebody's putting into their body, because somebody could be, and oftentimes is, having symptoms, and I can't even tell you how many times this comes up, that people are having symptoms because of the supplements they're taking, and being but usually too much, or taking right supplements at the wrong time. Vitamin B, for instance, vitamin B12, never dose that at night, right? So these are very, very important things to think about. And so usually with somebody like Laura, we'll start by doing a full history and psychotherapy, getting to know her past experience with providers, what's worked, what hasn't worked, family history, social history, what other drugs she's taking, what supplements she's taking, what her diet's like, what her physical life is like, exercise, movement, do a full stress evaluation in terms of where she perceives her stress is coming from. Is it work? Is it home? Is it family? Is it relationships with other people? Is it self-actualization stuff, existential crisis, whatever it is, really diving into all of that. and putting together a comprehensive understanding of who Laura is, and why perhaps some of these other therapies haven't worked. And then asking her really, focus on what she has done that she uses to self-soothe. And then starting to introduce some, where appropriate, supplement modifications. And then for her, for somebody like Laura, she could be a good candidate for ketamine-assisted therapy. We usually gently introduce ketamine to somebody like this. But they are generally a good candidate for ketamine. And ketamine is nice because if somebody's still on an SSRI or SNRI, they can still use ketamine. And so that's not contraindicated. So that is nice for somebody like that.
Dave, I'm going to ask a question.
Please.
Are there anything that you're screening for that would be like an absolute no for ketamine or MDMA or psilocybin? That would be really contraindicated.
So yeah, definitely yes for MDMA and psilocybin. We try not to provide, so diagnosis wise, no bipolar disorder. Personally, it's not worth the risk. There's lots of other options for people with bipolar disorder other than psychedelics, and it can trigger mania, which is very, very challenging to treat and very damaging. So we do not recommend psychedelic medicines for people with bipolar disorder who have especially a history of mania. We don't recommend psychedelics for people with a history of psychotic disorder or who have a recent family history of psychotic disorder or delusional disorder. These can dramatically worsen outcomes. We also have to be really careful with folks for MDMA, psilocybin, and ketamine, people who use, or cannabis as well, people who use amphetamines should not be taking their amphetamines while they're taking these other medicines, because amphetamines are very, very powerful stimulants, and they can basically be dislodging, for lack of a better term. So when you take a dissociative, like even THC levels of dissociation, or ketamine or any of these other medicines, and you combine it with an amphetamine, you're kind of like rocket shipping the dissociation, which can basically leave people feeling very ungrounded, and it can actually promote psychotic behavior and delusions, and paranoia. So we do not encourage the use of those. And if people are using those, we usually ask them to stop using them for certain, anywhere from 3 days to a couple weeks before we actually administer the medicine. Ketamine is my favorite in general because, number one, it's legal, it's the easiest to access, it's the safest at this point for people to access, legally speaking, and the pharmacy can ship it to your house, so we know exactly what you're getting. There's very few contraindications for ketamine with respect to other medicines people are taking, so that is nice. The major contraindications are people who have any history of like bladder irritation, bipolar disorder, again, psychotic disorders, and serious heart issues, arrhythmia, high blood pressure, things like that. We try to avoid using ketamine. But other than that, it's very, very safe and well tolerated. And people have certain addiction disorders we don't recommend, as we talked about earlier. MDMA and psilocybin, however, should not be administered with SSRIs or MAOIs or any drugs that augment the functioning of the serotonin system, can result in serotonin syndrome, which is deadly or can be deadly. And is an absolute emergency that somebody needs to go to the hospital for right away. So if somebody is taking an SSRI or an SNRI like Laura, we would generally recommend ketamine before we would ever recommend MDMA or psilocybin. We'd require that if they were going to go down like a MAP study path, for instance, that they would taper off of these medicines for at least 2 to 4 weeks, ideally 4 weeks, because that's how long it takes for that to get it completely out of your system before we administer one of these other medicines. Does that answer your question?
Our inbox a few times is, what about folks with epilepsy or seizure disorders?
That is a good one. That reminds me, and I think I'm trying to remember, we don't get that many folks with epilepsy coming into us, but if I remember correctly, we do not typically recommend doing either of these medicines with folks with epilepsy. I think we have to proceed very cautiously because epilepsy comes in lots of different forms. There are people who have had epilepsy as children who have never had a subsequent episode. There are people who have epilepsy currently who have had episodes every week for years. And there's lots of different extremes. And so I think generally the way we approach this is, if you have a seizure disorder, then we eliminate any drugs and do not administer any drugs that could, what we call, decrease your seizure threshold. There are lots of drugs that can do that. Magnesium is a big culprit of reducing seizure threshold that most people don't think about. However, there are cases where somebody has been seizure-free for a decade, for 5 years, and never had a seizure, or only had a seizure one time in their life, and it was diagnosed as epilepsy, but it was only one time, or it was drug-induced or something like that many years before. And in those cases, on a case-by-case basis, we will carefully administer medicine where appropriate if there's a good fit. But only in cases where there's been a substantial period of what we call seizure freedom. So usually 5 to 10 years of seizure freedom. That's a great question, Allie.
Yep. And we do have, quite a few people asking about bipolar disorder. And so, this just hasn't been researched very well. And I know that there are new studies that are wanting to look at this indication. But as Dave said, I think generally it's an exclusion for current trials, and probably a really high risk population to work with.
Yeah, I mean, it's really it's a great question. I mean, trust me, I love working with people with bipolar disorder. I wish we could safely use these medicines more with them. It's really a risk versus benefit thing. And ultimately, bipolar disorder is one of those disorders where, especially when we're talking about bipolar 1, it is, if somebody gets into a manic or depressive state, those who did not work directly with people in those severe extremes, the manic or depressive state, do not realize necessarily that those states put people at the highest risk of suicide than any other single mental health crisis, the extremes of the bipolar syndrome. So when you administer psychedelic medicine to those people, we are extremely, extremely cautious, because if there's any chance at all that somebody would perhaps transition into either a manic or a severe depressive state before, during, or after, usually it's during or after, then it's just not worth the risk, because we have other tools. We have lots of other tools that we can use. And lithium is actually a tremendous medication for bipolar disorder. It's the oldest and still the best. So and CBDA, again, potently mood stabilizing, fantastic for bipolar disorder, has no side effects. Apollo, really great mood stabilizer. Lots of bipolar users with great success, no side effects. So these are other tools that can be used in conjunction with psychotherapy that would be better options for people with bipolar. There's one caveat with bipolar that I think is important to note, which is that bipolar is also the most misdiagnosed disorder in the United States. So people who have mood lability, or who just like lots of mood shifts all the time, often get misdiagnosed as bipolar, and they're actually not even close to bipolar. Bipolar has a very specific definition that needs to be screened for, which is having had a distinct manic episode. Just need to have one manic episode, which extends for days, where you have energy enough to be awake 4 days, not because you just can't sleep, but because you feel more alive than you've ever felt for days, and you start spending lots, and you start spending lots of money that you don't have. You have lofty goals and grandiosity and sexual promiscuity and lots of other things that meet the criteria of mania. But probably 25% of people, and probably 50% of children who are diagnosed with bipolar disorder, don't actually have bipolar disorder. So as a clinician on your side, it's extremely important to look extra carefully at these folks who come to you with a pre-existing diagnosis of bipolar disorder, and rescreen every single one of them through the entire 10 questions or whatever that you need to ask to understand whether or not this is real bipolar, or whether or not this is bipolar 1 or 2, or whether it's just somebody misdiagnosing it because they saw a person who was like bouncing off the walls because they took too much drugs. Also, drug-induced bipolar disorder is not bipolar disorder. It's drug-induced bipolar disorder. So bipolar disorder also has to be diagnosed in the absence of substance abuse. Another thing that most people forget. And so that's why rescreening people often for bipolar disorder and making sure that you don't doubt necessarily the diagnosis they're coming in with, but do the investigation necessary to understand what's going on with this person are absolutely critical to getting to your end goal. And you probably will find that 25 to 50% of your patients who come with a diagnosis of bipolar were misdiagnosed for all of the reasons that I just described to you. And they may be good candidates for psychedelic medicine.
Awesome. Well, this has been so informative, Dave. Every time I hear you speak, I learn so much. And we didn't get to all the case examples, so I'm going to have you come back and talk to us some more about how you approach these cases and some imaginary work about, maybe when we have more medicines available for clinicians to use legally. You can stop sharing your screen if you wish. Sorry, I know you probably have to go, but I'm going to keep the room open for another 15 minutes if anybody wants to stay and hang out. But I know your schedule is busy.
I actually have 15 more minutes. So if you want to keep going, we can keep going.
Sure. Anybody that wants to stay, feel free. If you got to bounce, we'll post the video later, and we appreciate you showing up. So would it
be worth doing more cases, or should we just do an open Q&A? I'm fine with you.
Yeah, I mean, we have quite a few questions coming in. So let me see if I can pull some questions. One person was asking about, how would you decide if someone should take psilocybin or MDMA? And we can just frame this up like this is 2025 and there's been approval, and someone comes to your clinic. How might you look at ketamine, MDMA, and psilocybin as the options?
It's a great question. This is a common one. So I guess the first thing is focus on if we think about how these medicines work, like I mentioned earlier, in that they're all kind of helping people in a similar way open up access to that beneath awareness space, the subconscious space, and pull material from the subconscious space into our consciousness, into our awareness, and then work with that through integration. Same process for all three medicines: preparation, medicine session, integration. Then the major differences between them are how the actual experience feels to the individual and how long they last, and the side effect profile or the contraindication profile. So the way that I would decide or help a client decide what to do or is really about educating them around what is the least risky medicine for them to do that is it's safest all around. So, if people are taking SSRIs, very commonly, I think over 20% of America is on an SSRI. If they don't want to taper off of that for 4 weeks before doing a session, which a lot of people are afraid to, then you probably only have ketamine as your option, right? So that pretty much eliminates right there the other two options. If the person's willing to taper off of their SSRI, ketamine is still a great option because you can use it during the tapering process. It helps make the taper easier. Serotonin, SSRIs have a very strong withdrawal syndrome for many people. Ketamine is a very gentle psychedelic experience. It only lasts 1.5 to 2 hours. It's very highly controlled. It's very easy to access. It can be done in the comfort of your home remotely during an SSRI taper safely. And it also, because it's great in a gentle way for people who have never, ever had a psychedelic experience before. So all of that said, ketamine, I think in general is my favorite go-to, regardless of legality, just because it's the easiest and safest to use in lots of different settings with lots of other potential issues that we might have to manage along the way. If a person doesn't have any contraindications to MDMA or psilocybin, and we could do either of them, then it becomes a matter of cost and it becomes a matter of availability, because when you think about MDMA and psilocybin, you're talking about 8 hours with 2 therapists ideally, and 8 hours with 2 therapists is very expensive, and there's more integration involved in a lot of cases, and that might be cost prohibitive for people. So keeping that in mind is very important. And also, but I think generally speaking, my preference to introduce somebody who's naive to psychedelics, which I think is most people who we engage with, would be ketamine first, MDMA second, psilocybin third. because those kind of increase in intensity of experience over time in terms of how altering they are to your sensorium. And people who have never experienced psychedelics before can have great experiences on psilocybin with adequate preparation and support, but they're more likely to have unpleasant experiences also, which need to be accounted for. So that's what I would suggest in general as a rule. You can kind of use those things as guides to help you navigate.
Cool. We've had a number of people ask about using microdosing of mushrooms for tapering SSRIs. Any thoughts?
So that's also a great question. I think the challenge with answering that question is we don't have enough data yet to give you an answer. What I will tell you is read the recent Nature publication by Paul Stamets and team from Quantified Citizen. Fantastic article and study, and thousands of people microdosing in different ways around the country. It is one of the first crowdsourced studies that was done in a sufficiently large enough population, has shown that microdosing is effective at improving mood and probably improving cognitive function and reducing anxiety on the whole. The challenge with microdosing that most people experience is that they microdose too much and they dose wrong, and that people think a microdose is like half a gram of psilocybin or half a gram of mushrooms, but they don't realize that that's actually that's, believe it or not, closer to a macrodose than it is to a microdose. And that a microdose is really supposed to be, according to the people who really pioneered this idea, which was Jim Fadiman and Paul Stamets, which is a microdose is meant to be sub-threshold. So what that means is beneath awareness, right? At a level where you just barely notice that things are different, but they're not different enough that they would alter your functioning in any way. That is absolutely critical. And that you want to microdose, when you do microdose, typically one microdose every 3 days. So not every day, because you want that period in between for kind of like a mini integration of what you're learning from your days when you're on versus off. So those are the most important considerations. And if you read Paul Stamets' studies and the studies that I think Jim Fadiman is on, and a number of other really excellent folks, I think there's 2 large studies that just came out in the last couple of years. These are very, very informative about what people are getting out of microdosing and what the different stacks are, like the Stamets stack, which includes, I think, niacin and something else that basically helps to give people more bioactivity of the psilocybin dose. But I think the most important thing is just noting that keeping the dose low where it's sub-threshold is absolutely critical. Otherwise, you can make symptoms worse. People can become destabilized if they take it too much too often. But you'll see from those papers, I think it's fairly strongly suggestive that yes, people can use microdosing carefully and properly at the right doses to wean themselves off of antidepressant medication. It just needs to be done very carefully, ideally in the conjunction with their prescriber, who is able to monitor them during that time. So hope that answers your question.
Yes, it does. And just to add to that, the pharmacology of taking mushrooms and antidepressants seems to be that if you're taking microdoses, there wouldn't be a health risk in taking low doses. With higher dose sessions with psilocybin and antidepressants, there might have a blunting of the subjective effects, but the drug-drug interactions seem to be low risk for co-administration, which isn't the case with SSRIs and MDMA or other MAO inhibitors. I posted a link in the chat from Erica Zelfand, who presented on this a few months ago. A lot of good information there. And I've personally heard of a number of people have had success with using psilocybin mushrooms to taper off of antidepressants. And what seems to be happening is modulating the withdrawal symptoms, as well as the serotonergic effects in the brain we know become downregulated from antidepressant use. It's just how they work. They reduce the serotonergic transporter proteins. and it takes some time for those to recover. And we're going to be putting out a paper pretty soon. I think it's coming out this month. We just recorded a podcast, so I'll share that. And it's talking about some of the research we did looking at MDMA participants from MAPS phase 2 studies that had tapered off of antidepressant medications. And they actually had a much lower response rate to MDMA assisted therapy in terms of their PTSD symptom reduction. And they also had lower blood pressure readings during the MDMA administration, which really speaks to there not being the receptors in the brain to release serotonin, norepinephrine, and dopamine. So a lot to learn there. And the research is really compelling and interesting that's coming out around this topic.
Yeah, that is very interesting. And actually, I don't know why this reminded me, but of this. But I should mention that cannabinoids interact with psychedelics in different ways. So THC augments ketamine and augments psilocybin psychedelic effects. THC and CBD and most cannabinoids attenuate or reduce MDMA's effects. CBD itself, alone without THC, attenuates the psychedelic effects of ketamine and psilocybin. So this is really important to note because, again, some of these CBD products that I'm mentioning can be really useful in the moment when somebody's having a hard time. Also, not just afterwards when you're trying to manage their mood stability. But this is stuff that hasn't been studied very much, but we know it anecdotally from seeing tens of thousands of patients over many decades as a community that we've seen these effects. So just important things to keep in mind and tools that you can use to either augment an experience for somebody or attenuate an experience for somebody in the way that you wish if you need to.
Great. All right, we'll do one more question and then we'll wrap it up. There's a question here about, are we aware of any psychedelic medicines for the treatment of functional neurological diseases such as PNES?
PNES,
we can maybe just speak to it broadly. I mean, there are some trials happening right now at Johns Hopkins University looking at Parkinson's disease.
I see.
As well as anxiety related to Alzheimer's. So I'm not sure, the neuroplastic effects of psychedelics are really fascinating. It's been shown in non-human brains, and there's a company trying to target the same pathway, but without the psychedelic effects to see if that could help with neurological disorders or induce the growth of new neurons or synapses. But I would say it's all really early. And it's exciting, and we're going to be hearing a lot more in the coming years, and hopefully too actual neuroimaging studies to back up some of these claims of, what is neuroplasticity in the context of psychedelic medicines.
Yeah, this is a really important and interesting topic. Paul Stamets, talks a tremendous amount about this, and there's been a number of really interesting studies coming out about how psychedelic medicines, ketamine, psilocybin, and the components of ayahuasca actually seem to be able to facilitate neuroplasticity effectively, the retraining and reorganization of neural networks, or the acceleration of learning is another way to think about it. So that definitely seems to be the case. But I think one thing that's interesting and important to take into account is that the acceleration of learning needs to be done in a way that's very highly guided, because when you accelerate learning and you accelerate neuroplasticity, that's an open book, right? That means you can accelerate it good, and you can accelerate it or I should say not good or bad, but in a constructive direction or in a destructive direction. And so it's really, really important to have that grounding framework of safety, especially when people are microdosing, which people don't really understand, because even microdosing is augmenting your neuroplasticity in certain ways, right? And so we want to make sure that, again, you're not just microdosing because you need a little extra energy at work. You're microdosing because you're trying to solve a problem intentionally, and you're setting up the safeguards to make sure that you are doing it right and doing it thoughtfully and respectfully and not putting yourself at risk. Because if you microdose or you take psychedelics and you engage in maladaptive or destructive behavior, like for example, cigarette smoking, right? Which is a very common thing that people do when they feel anxious, then you're actually making the strength of the neural networks that associate managing your anxiety with tobacco, nicotine, and just the act of smoking stronger, rather than actually, making the other networks around healing and recovery stronger that you're aiming for. So again, just something to keep in mind.
Okay. Yeah. Thanks for all that. I'm going to go ahead and wrap it up. And I'm sorry if we didn't get to all the questions. We'll have Dave back again sometime. So I wish you all a wonderful weekend, and thanks for your attendance and sharing your information and yourself here in the chat. So do join us again another time.
And feel free to reach out if you ever want to connect with me. You can find me on social, on Instagram at Dr. David Rabin, or on Twitter at Dr. David Rabin. I'd love to hear from you. And you can also check out my website, apollo.clinic or drdave.io. And you'll find all the work that I'm doing there. I think Ali just shared it. And you can also reach out to me there. And if, we always do like cross referrals of patients. So if you have clients that you'd like consults, we're happy to do it. We actually have openings now, which is unusual. So I'm always happy to collaborate. And we always love to have a nice network that we can refer out to as well. So it's good to grow together as a community, and really appreciate all of your time here today.
Awesome. Bye, everybody. Take care.